when you look at labral tears and their structure within the hip joint, so kind of what you got to remember is, so you've got acetabulum, you've got hip, so femoral head sits in, okay? So it's obviously bone on bone. So labrum offers kind of two kind of roles. So one is it acts a bit like a cushion between femoral head and the acetabulum, so that they're not bumping against each other. So kind of it's this kind of shock absorption impact area between the joints of the two. Yeah. The other one is very similar to the shoulder in terms of it also increases the I guess the depth of the joint, so it keeps that femoral head sitting in the acetabulum. Quite interesting. Labral tears in the hip normally occur, they're more overuse injuries. So it's that idea of this constant wear and tear, this constant impacting of the hip. So we kind of, one of the thought mechanisms when you're thinking about labral tears in the hip, you kind of straight away want to bring your brain towards kind of overuse, poor mechanics, poor force distribution through the pelvis. Whereas with the shoulder, if someone goes off with a labral tear, you're generally thinking more stability, hypermobility, increased range of motion stuff. Does that make sense? So it's kind of important to understand the mechanisms. Of hip, you're thinking kind of agonist-antagonist dysfunction, excessive force loading through the quads, which is why a lot of the times with labral tears, it's associated with runners. You get a lot of it with runners. So it's that idea of repetitive, continuous force loading through the pelvis unevenly because of hip flexor tightness or rec fem dominance or something like that. Does that make sense? So kind of that mechanism is important, because I guess labral tears in the hip are a huge example, a really good example of this idea between cause versus symptom. Like treatment of acute labral tears, if it's not surgical, like obviously a lot of them are surgical where they'll suture it back on, but let's assume the acute labral tear is non-surgical. A lot of it then is the treatment is dealing with symptoms, so releasing of hip flexors, releasing of rec fem and those structures around the anterior, if it's an anterior labral tear, kind of posterior labral tear as well, but we'll just assume anterior labral tear, yeah? And releasing the pressure off of those. So what that'll allow to do is the femur and the femoral head to slightly realign, and it takes away that acute pain, yeah? Cause is a lot more focused then towards that balance between why is it anteriorly pulling. So when we think labral tears, it's really important to understand mechanics. It is more to do with this repetitive, uneven force distribution through the hip joint, which leads to a wearing and tearing essentially of the labrum, because the labrum in the hip is more to do with you know, giving me this cushioning and this force absorption portion of the hip, unlike with stabilizing to the shoulder. So unlike with shoulder stability, it's more strength based with the hip. So as opposed to going, oh, you have a labral tear straight into mid-min, you got to think more force, more hamstring glute. Now, you generally will notice it, but it's kind of what to notice. Yeah. Because the problem is a lot of the time with labral injuries, they're masked or disguised as tight hip flexors. Yeah, okay. Because, and to be honest with you, the mechanisms are almost the same. Yeah. Do you know what I mean? It's the tight hip flexors and rec fem's dominance in the running stride that eventually leads to the labral damage. The problem is I guess a more apt question is, when does hip flexor tightness stop and labral damage? It's hard to distinguish because you're going from 4 months of hip flexor tightness, where it is hip flexor tightness, to suddenly 1 month later it's labral damage because now the labrum's flared up. So the first thing with determining of how do I know when it's labral, does it just happen, is chronic long-term hip flexor tightness is one thing that you look for. Yeah. Impingement pain in rotation, especially in that internal rotation of the femur. So when the femur becomes internally rotating, it pinches onto the labrum. I guess another indicator to clients and going, you know, how do I determine one from the other? Labral damage, once it's happened, doesn't ease off. Like if I've got tight hip flexors and I do a really good stretch and a really good mobility and a really good release, I get release of pain.
Yeah, okay.
Yeah, it's when I don't, that's when you start looking at more structural problems, when I'm not getting a release. Yeah. Whereas if you got a client who comes in going, I've started training for the Gold Coast Marathon 8 months ago, I've had hip pain for the last 4 months, that's progressively got worse, and when I used to stretch, it used to go away, but of the last month it just doesn't seem to be settling down, then you're probably thinking of that. And generally speaking, they are overload injuries in the hip because they are more based on like force loading, force distribution. They generally are more chronic overload injuries as opposed to kind of that acute stuff where you get more of that in the shoulder. So even then, if this client's going, I started training for the Gold Coast Marathon 6 months ago, 3 months ago, my hips, I was getting really tight hip flexors. I've seen a massage or seen a physio, and you know they'd release to be really good, but for the last month it hasn't really eased off. You're probably just an acute inflammation, or you've just you've irritated the labral. The labral tear isn't probably something that you're looking at. Volume and progression are really big important things to look at. Yeah. If it's a non-surgical labral irritation, the first thing to do is address volume of training. So how much training they're doing, and also intensity of training. Because it's all about force, you know what I mean? The more load I place through it, the worse it's going to get. The more I back off the load, the more I allow recovery and rest, the better. Then on top of that as well, it's that history, the past history. Probably number one causes of acute labral stuff is rapid increases in training load, volume or intensity. You know, the first question you're normally asking is, what's changed over the last 6 months? Have you started running? Have you increased? Do you know what I mean? Like if you think about, like if we go back to what I was saying at the beginning, if you think about the labrum a bit like shock absorption, it's all to do with how force comes into the hip, is absorbed and transferred. So then your head's thinking, okay, well, what's happening? So it's going to be either there's too much force too quickly, the body's not able to cope with it, so volume, intensity. Surface becomes another big impact. Going from track sessions to cross country and things like that can have a big impact in it. It's not generally something you see in a lot of field-based sports because their intensities are high, yes, but their volumes are low. And because there's lots of rotationals and sideways and lateral movements, they're not doing the same movement. You gotta remember, labral stuff, it's this continuous non-stop through the hip.
And also, like with the rotational stuff, they usually do a lot of rotational training work.
Yes, exactly right. So they're normally strong. Yeah, they're normally stable in that area. Whereas it's all about the repetitive non-stop, just impact. So the first thing you straight away look at is going, where's your volume, where's your intensity? You know, have you changed training surfaces? Have you changed even equipment, shoes and things like that can have an impact